Thank you. Good morning. I'm Dr. Erica Sutton, also from the University of Louisville, an assistant professor of surgery. Space, the final frontier. Yet, it is not where our story began. Our story began here in Houston, in fact. So NASA was looking to initiate surgical capabilities in space. The problem with surgery in space is wound containment. How do you keep droplets of blood and body fluid that are so unavoidable but easily contained here at the Earth's surface from floating into the air? The answer came in the aqueous immersion solution system. In 2012, the astrosurgery team from the University of Louisville, led by Dr. George Pantelos, first piloted and tested the AISS to control the site of surgery or trauma in reduced gravity. The dome-shaped structure required portals for instruments to reach the operative site. These portals, of course, naturally resembled the ports that we use commonly in laparoscopic and arthroscopic surgery. But there is one caveat to those trocars. They must be leak-free. So the trouble with trocars, both at 0 gravity and 1 gravity, where most of us are used to operating, is that there is copious leakage. This copious leakage leads to wasted CO2 as well as saline. This leads to wasted money as well as adverse events. Heretofore, we've been tolerant of these events. So some of them are expected and accounted for, such as metabolic acidosis, the hypothermia, or the hazardous conditions of a saline-soaked operating room. There are rare and fatal events, however, with increased CO2 usage, such as CO2 embolus, or the metastatic spread of cancer at port sites, and potential compartment syndromes. The increased costs are manifested in increased OR time and wasted resource utilization, as well as potential morbidity and mortality and longer emergence times for patients. What is the exact cost of wasting CO2 and saline, which is heretofore normally tolerated? Well, a tank of CO2 is relatively inexpensive in the operating room, $8 to $58. However, we are able to reduce that by 60% with a leak-free trocar, with a savings of mildly $5 to $35 per case. A bag of saline, also very inexpensive, at $8, and the average use being 4 bags per case, but we have been shown that we're able to reduce that by about 50% in animal testing. And so that, and if you consider the operating room time of about 100 per minute, we're saying that these are small savings over procedure. However, it is the number of procedures and the spread of replacing leaking trocars with a leak-free trocar that we think is the market value for this product. So we estimated the total market at about $1.2 billion by the 10 million arthroscopic cases per year and conservatively 6 million laparoscopic cases per year. We assumed an average of 3 trocars per case for about 48 million trocars per year being used. While this is projected to increase, this would be a conservative estimate. The served available market, meaning how many trocars could be replaced with a leak-free trocar, and in this sense, it's 100%. We used a conservative estimate of the initial launch of 5%, saying that we may only reach the initial 5% of the market with first launch. So currently, the cost of trocars is covered under facility reimbursement and our class 1 or 2 devices with an expectant 510K market clearance. So the fastest path to market for this product at its current stage of development is to license our trocar design. Our solution, to give you some specifics of the design, is to remove the leak path from the channel of the trocar. And so without leaks, decreased metabolic acidosis, increased emergent times, fewer complications, and some of the adverse, rare, but also common events that we've discussed. There's an international patent pending for this product. To break apart the product, to show it a little bit better, there is essentially a dual valve system that makes this product leak-free. And here's some testing from our human cadaver studies, which demonstrated in red the consumption of CO2 in a laparoscopic case that I performed lasting roughly an hour and 15 minutes, and a 60% reduction in the CO2 consumed in the cadaveric studies. The human cadaver model actually tends to be even more leaky, so this reduction is actually quite significant. It would seem that a forward button would be awesome. To date, we have had component refinement, but our request is either licensing or $250,000 to complete the sequence of component refinement to take this product to manufacturing. We have refined our steps in component assembly, performed bench leak tests, as well as cadaveric fresh tissue tests and animal testing. Thank you so much from our team.